بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. مساكم الله بالخير. Thank you very much for all our audience. Thank you very much for Hikma Company to arrange this through the Saudi Heart Association. Tonight, we are going to have 1 hour discussion about COVID and cardiovascular disease. My name is Mustafa Al-Shameri, a consultant cardiologist, head of adult cardiology in Cardiac Science Department, King Saud University. And I am the head of coronary care unit in the King Saud Medical City. Now, we are so pleased tonight to have with us the Saudi Heart Association head, the president of Saudi Heart Association, Dr. Walid Al-Habib. Dr. Walid Al-Habib, he is a consultant cardiologist. He's a senior consultant cardiologist. He is one of the founder and establishing heart failure program in King Saud University Medical City. He is very active researcher. He has a registry of the heart failure, and he was the head of heart failure subgroup in the Saudi Heart Association, and he is still the head of both, the head of the heart failure group and the president of Saudi Heart Association. We are so lucky tonight to have Dr. Walid Al-Habib, who will start talking about the COVID-19 and cardiovascular outcome. Then I will present my talk about the hypertension and COVID-19. And after that, we are going to listen to the question and answer from all of our audience. Again, I will thank the audience who joining now. We have reached already something above 1,000 audience at the moment, and they are increasing in number. And then we thanks again the Al-Hikma Company for their efforts to make this successful. And I will now call Dr. Walid Al-Habib to start his presentation.
Thank you very much, Dr. Mustafa, for this very nice introduction. And I do thank as well Al-Hikma for sponsoring such an event. As you can all see, this is becoming the norm now to have our meetings and events live, and each one of you from his comfort of his home. And this is probably going to change a lot of our interactions and education in the future. Having schooling through webinars and having events and meetings through webinars is reshaping a lot of our practice in the coming future. So maybe Corona is not all bad. I will talk today about the COVID and cardiovascular implications. Allow me to open it. And do you see my screen?
Not yet.
Not yet. Let me then share it again. Share my screen. Oh, okay. Here, sharing. Okay. Now I think you see it. I will make it slideshow. So it's shared now, right? So basically, COVID-19 is relatively a new event that just actually put its print on us a couple of months ago on the whole world. It is based on our experience started based on a lot from previous the SARS-CoV-1 before, but we're building our experience now of what it causes to the cardiovascular system, mostly by case reports. And as you can all see, the literature has every day something new and some new paper that talks about it. So literally, if we talk theoretically, as any virus we see daily in our daily practice, it can present to us with a myocarditis, just theoretically. It can present with stress cardiomyopathy. It can present with severe infection and shock, or can cause myocardial infarction either as a demand or actual clotting and clogging of the vessel. It can also cause tachyarrhythmias and coagulopathy. All this is theoretical, like can happen in any virus. But what is specific about COVID-19, and what do we know about it till now? Most of the reports came, of course, from the Chinese, because the disease initially started there, and it hit them hard at first. And their reports were mainly mentioning myocardial injury, which is a total non-specific term, but depending on the elevation of high sensitivity troponins in general as a marker of myocardial injury, that's how they reported it. With new ECG findings or echocardiographic abnormalities. And in their reports, it was present in at least 7% of the patients in overall, and about 22% of the ICU requiring patients. 12% of patients without known cardiovascular disease had elevated troponin levels or cardiac arrest during hospitalization. So it happened in all population, but mostly in those who already had a cardiovascular disease, underlying cardiovascular disease. There are three main patterns of myocardial injury to happen with COVID-19 as such. So the first, and probably what was thought to be the most common, is a rise in troponin as part of the inflammatory biomarkers, other inflammatory biomarkers, D-dimer, ferritin, interleukin-6 mainly, and lactate dehydrogenase, raising the possibility that this just reflects the cytokine storm or secondary hemophagocytic lymphocytocytic more than isolated myocardial injuries, just a generalized involvement of the whole body. The second possibility is patients presenting with predominantly cardiac symptoms, suggesting a different pattern of viral myocarditis or stress cardiomyopathy. So the main involvement is the myocardium itself causing injury and presenting as the usual myocarditis or stress cardiomyopathy Takotsubo disease. The third is the myocardial infarction, the actual STEMIs and non-STEMIs that we see. The virus causes plaque disruption and instability, hypercoagulability was found, or just demand ischemia and type 2 myocardial infarction. And this is how many of the Chinese papers came out in the beginning and in the early part of the disease, presenting to us the difference between patients who had high troponin or what they labeled as myocardial injury versus those who did not. So most of those who had myocardial injury had an underlying disease, whether it was hypertension, coronary heart disease, cardiomyopathy, diabetes. These were the highest people and COPD to be susceptible and for the disease, for the infection, and for the injury and the worst outcomes. These patients were more likely to have ARDS, have arrhythmias, and coagulopathies and kidney injury. And of course, those patients who had high troponin were more likely to die. So in a graph, those who had previous cardiovascular disease and elevated or myocardial injury during their disease had the worst outcome, had the highest mortality, followed by those who had myocardial injury without a previous cardiovascular disease. So having a myocardial injury or having myocardial involvement during the disease was the highest risk for mortality, followed by those who had cardiovascular disease to start with prior to that, and those who don't. Not just troponin was a marker of myocardial injury, but as we know, NT-proBNP or natriuretic peptides were also a high marker, a marker of myocardial injury and heart failure. So the higher your NT-proBNP, the higher chance that you will die from the disease. And the combination of both high troponin and high BNP or natriuretic peptides increased the risk of hospitalization and death. have a quite similar paper that came out from Wuhan as well, but from the other hospital, showed very similar. They talked about it here, labeling it as cardiac injury, not specifically troponin rise, mainly cardiac injury. And now, as you can see, those patients were also at higher risk if they had underlying chronic disease, whether it was heart or kidney or lung disease. The higher the chance of having worse outcome and having myocardial involvement. These patients, as I said, were also a lot more likely to have higher NT-proBNP and other markers of inflammation like C-reactive protein and procalcitonin as a marker of overall body involvement. They were more likely, again, to have ARDS, electrolyte disturbance, acute kidney injury, and they were more likely to die. So the survival in this report was mostly dependent on whether you had evidence of cardiac injury or not, whether it's just a rise in troponin or NT-proBNP or imaging involvement of that. Now, some might say that this is not very much new news because we already know that troponin is an indicator of high mortality. That is quite true, but what we didn't know what was the exact involvement of these patients. In a third paper, also from the Chinese, the patients who died were more likely to have, of course, sepsis and respiratory failure, but also heart failure, coagulopathy, kidney injury, and hypertension. These patients were more likely to die if they had. So general manifestations of sickness were there. So back to, and this is interesting because it was just sent today, and it's in press from the Journal of Cardiac Failure, summarizing the possibilities of these of the involvement of the heart. It could be either part of the cytokine storm that can happen, could be direct involvement of the muscle of the heart causing myocarditis, myocardial infarction, as we said, either type 1 or type 2, or microangiopathy, and manifesting with high D-dimer. Some of these patients actually presented with PEs, and that was their main manifestation of sickness. So let me touch on, and as I said, most of our learning came across with the reports and case reports that have been mentioned and published, and this is one of the main ways that we learn from each other. And so let me touch on some of them. This is one interesting one, as you can see. This was a young patient who presented with typical ST elevation in lead 1 AVL and V4 V6 to V6. You might think this is an anterolateral infarct, but the coronaries were normal, and the patient had some mild LV dysfunction, but edematous, and the presentation was just myocarditis. Another patient that was now the biggest focus of the world was on the lung findings. You see, looks like inflammatory changes, could be pulmonary congestion, might progress to be ARDS, but this was a patient who already had heart failure to start with in their report, and the patient actually presented with cardiogenic shock because the reserve of the patient was very low. So you could, as I said, you could have underlying cardiovascular disease, so your risk is high to develop complications and mortality, or you can develop new onset myocarditis or a heart failure. This was a patient who who presented with lung findings, just non-specific PVCs, and then had prolonged QT and went into VTAC and arrhythmias. So as we all know, there's a risk of tachyarrhythmias, and I'll show you in a while some of the etiology behind that. And prolonged QT, that's why when it was postulated to use hydroxychloroquine and azathioprine, there was the major risk of developing prolonged QT and VTAC and death, of course. This is interesting. If you look at this patient had already wires of a previous surgery. So this patient actually had a transplant. He was a transplant patient and presented with the typical symptoms of corona. And the challenge here is these patients are on immunosuppression already. And would be the challenging here is the management of stopping some of these immunosuppression treatments until the patient improves and recovers. So as I said, they can present with ST segment elevation, non-specific. They can present with cardiogenic shock or present with decompensated heart failure and what is challenging in the heart transplant recipient patient. This is another interesting case where you can see a lot of lung involvement and non-specific ST changes. And here the coronaries on CT was totally normal, but even cardiac CT can give you some findings on the of edema and some perfusion defects in the myocardium, just showing you that this is classic myocarditis, not an MI. Another classic, when you see such a picture on the angiogram, this is a typical Takotsubo finding. The coronaries were normal, and that was the only way. Of course, when you have what looks like an MI with normal coronaries and impaired apical segments, but well contracting basal segments. This is stress cardiomyopathy, and both Takotsubo and reverse Takotsubo has been reported in patients with COVID-19. So COVID-19, as I said, can cause direct tissue invasion with myocardial injury and can cause release of cytokines interleukin C6, mainly implicated here with extrasympathetic hyperactivity or cardiomyocyte injury. You can have concomitant QT prolonging drugs, and all these have been implicated in the theory of tachyarrhythmias. Even heart blocks have been reported in patients with COVID-19. I know I'm not going to touch on this in deep detail. Dr. Mustafa might touch on it. There's a lot of thought about the role of ACE2 receptors in COVID-19, and it's probably the source of entry into the lung and to the myocardial tissue. And we do block, and we know that when we use ACE inhibitors, we block ACE1 and increase ACE2. But you have to remember that ACE2 have very strong role in anti-inflammation, anti-fibrosis, and vasodilation, and has been implicated in reducing the inflammatory effects of infections. So it's a balance. When you have increased angiotensin 2, if in case you stop your ACE inhibitors or ARBs, you will have a reduction in ACE2, which will eventually cause increased inflammation, increased vasoconstriction. So it's a balance that you have to weigh when you talk about it. So where this was a very nice report looking at the progression of the disease according to the viral shedding. The longer the duration of the viral shedding you have, the longer the possibility of complications like coagulopathy and vasculitis, increased risk of heart failure, and increased risk of cytokine storm, and the implications of cardiovascular complications that we have talked about. As I said, I like this as well, has been just published a few days back. It's not all bad. There might have been some good things coming from Corona. Now, what was bad is, of course, there were unfortunately delays in STEMI recognition. There have been reports worldwide of delayed presentation of patients presenting with STEMIs and complications or late intervention. Failure to optimize guideline-directed medical therapy. I have patients who have been unable to see them to optimize their medications. Delays in ICDs and VADs and transplantations, of course, and suspension of many clinical trials. One of our major trials have been suspended because of the COVID-19. But on the contrary, we improved on many things. So telemedicine, as I said, has improved a lot. We have been seeing patients live through programs like this in the clinic. So live communication with patients, and this might live with us for the future. We have expanded on some infrastructures and the need for nursing visits and palliative care and home visits to manage these patients, and we will learn from that for the future. We will learn again in other quality measures and improvements that we need to look at. Now, in upcoming, inshallah, things will recover and improve. We will have some challenge in those patients, outpatients and elective procedures that have been delayed. It will be challenging for the healthcare system, and we need to track it very well. And the transplant list that has probably been prolonged, and there might be, because of the COVID-19 that hasn't been tracked for everyone, there might be an increase in the incidence of heart failure patients and the disease progression because of viral involvement that might not occur immediately or maybe later on. So, and before I end, I would like to remind you or point your attention to our Saudi Heart Association groups and societies have thankfully developed lots of guidance to manage patients who present with COVID-19 or in the era of COVID-19, whether they had acute coronary syndromes, heart failure, how to do echoes and imaging, and those with arrhythmias. And it has been promoted by the Saudi Health Council to all healthcare systems in Saudi Arabia, and I hope it will be very beneficial. Thank you again for having me, and hope it was very beneficial. And thank you, Dr. Mustafa.
Thank you very much, Dr. Walid, particularly for the development of this quick guidelines in your presidential care of the Saudi Heart Association, and it is really very informative. It is almost similar to the big societies guideline. We appreciate this, and then I will go for my presentation. I hope it will not take long time about my presentation, but I want to tell you that we have the communicable disease and non-communicable disease. The non-communicable disease is the heart and the hypertension, and the communicable disease is the COVID-19. So I'm going to talk tonight about the relationship between COVID-19 and hypertension, and what is the prevalence of hypertension and in clinical practice, and do we reach the goal for controlling the blood pressure, and then how harmful is hypertension during COVID-19, and then what is the role of combination therapy of hypertension, and then we will conclude. Hopefully we will have time for further discussion. Disclosure, I have nothing to disclose about this talk. And I want to tell you here that the global mortality is #1 mortality is hypertension worldwide. That's a report of WHO being reported in 2002. Subsequently, we need to know that the high blood pressure or hypertension will increasingly with age. So the age is the common factors for the development of hypertension, as well as for the consequences of the COVID-19. You can see in this study with the February 28, 2020, they said this is the first studies. They found that from China, they found that the old age, diabetes, hypertension, and cardiovascular disease are highly prevalent among COVID-19 patients and may be associated with poor outcome, as has been explained by Dr. Walid. You can appreciate here, if you are older than 79 or above 70, you will have a higher mortality from COVID-19. And that's very clearly correlated with the elevated of high blood pressure in elderly. This is the coronavirus, once the mortality of coronavirus or the fatality of coronavirus, that you can appreciate that the cardiovascular disease patients will die more likely than others, subsequently followed by diabetes, hypertension, and chronic respiratory disease, cancer, etc. So those issues associated with COVID-19, and they are associated with hypertension. Again, hypertension, you can appreciate that hypertension and COVID-19, they are associated with crowding. So the prevalence of hypertension is very common. The crowded, whenever the people crowded together, the likelihood of spreading of the COVID-19 is there. So the end result of both of them, in fact, is death by suffocation issues or suffocation from the COVID-19 respiratory distress syndrome. This is the summary of the symptoms with the COVID-19. As you can see, it is involved the respiratory basically and the fever. And then the first thing is cough over there. And then subsequently shortness of breath. So hypertension prevalence, are you hearing me well?
Prof. Mustafa, we cannot see your screen.
Yeah, you cannot see the screen?
Yeah.
I have shared that already. I don't know why. I am seeing that one. Okay, I will go back to that. You see the screen now or no?
No, doctor, not yet.
Okay, let me go for this one. Okay, share. How about now? How about now?
It's shared. Yes.
Yes. Yes.
Okay. The prevalence of hypertension, you can see that it is common in all over the world. It reached up to 55 in Germany. And then, as you can see, they are the same for the hypertension in our clinic. And it reached up to 40% in different parts of the world, in the Arab world and Saudi Arabia, it is 42 or 43% in average. So it is very common disease, hypertension, and then subsequently the disease affect the infection will affect the people with hypertension is more than the others. So what is the risk factor for the COVID-19 and what is the risk factor for hypertension? This is the risk factor for COVID-19. Age is more than 55, chronic kidney disease, diabetes, hypertension, cardiac disease, HIV, history of organ transplant, using of biological immunosuppressive therapy. So this is the risk factors for the COVID-19 development. So it is similar to the risk factors for hypertension. So hypertension, they share the risk factors with COVID-19 patient. So what is the treatment of hypertension with the presence of COVID-19? I just will go quickly for the story. In the beginning of hypertension, before in the era of Pharaoh in Egypt, they were different modality of treatment. All of them is primitive. And then the question of whether it is helpful to treat or not, similar to the situation now with the COVID-19, whether to treat, what is the best treatment, etc. It is almost the same time. So in 1905, when the discovery of sphygmomanometer and the blood pressure can be measured, people used to say that controlling blood pressure is harmful and it is an irrigation system. One should not attempt to control this blood pressure. Similarly to the mass vaccine, the mass immunity or the immunity of the people whom they are not really restricted at home. And then there was a controversial report going on up to the time in 1965 when they released a study which showed that the treatment of hypertension is important to reduce mortality and morbidity. And then subsequently, the guideline came to support that we need to control the blood pressure. And then this is the harm effect of the blood pressure. If you treat, you are going to avoid stroke, myocardial infarction, and heart failure. Similarly, if we treat COVID-19 before the development of multi-system disorders involving all the system of the body, that will be beneficial. And then in 1972, the first guidelines were recommended. Despite this, up till now, we are not reaching the control of blood pressure. 70% of most of the patients with hypertension, they are not controlled. So this is very important point for us as a physician that we don't do a good job up till now, up to this moment. Subsequently, the China report that it showed that there is a good proportion of patients with hypertension, but the control of hypertension in those group of patients is up to 10% only. And most of the patients with hypertension, they are on the treatment, including ACE inhibitor, ARBs, and other antihypertensive medication. But because ACE and ARB is the number one medication for the control of the blood pressure, that they start people talking about the effect of the ACE inhibitor or ARBs on the treatment of hypertension and COVID-19 and what is the consequences. And as have been alluded by Dr. Walid Al-Habib, that probably it is beneficial rather than harmful. And most of the people directed to this, although it is a balance, the knowledge is complex, but we are sure that there is a benefit of ARB and then angiotensin receptor blocker and angiotensin converting enzyme. So what is drug commonly used in hypertension? As we have said, it is ARBs and ACE inhibitor. And then in that sense, that the combination of ARBs and ACE inhibitor is important. As you can see, you can combine all, but the best combination is calcium channel blocker in the form of amlodipine with ARBs or with the angiotensin converting enzyme inhibitor. And the reason behind this is that the combination improves the compliance, and then as well as it is going to reduce the cardiovascular outcome. The second slide is not coming easily. Well, okay. So the combination is important, and we need to know that there is a vasodilatory effect of the amlodipine at the level of the angiotensin, at the level of arteries, and then there will be a vasoconstriction at the level of the veins, and then subsequently this will reduce the presence of side effect of amlodipine, which is like peripheral edema. So my slide is not coming, but I want to tell you that the people now convinced that the side effects going to be less with combination, and then we have to keep the combination of both angiotensin converting enzyme or ARBs with the calcium channel blocker in every patient who's affected by COVID-19, and that will going to help the patient improving. So now and then the guideline, all of the guidelines came to say to us that patients on ARBs or on angiotensin converting enzyme inhibitor should continue the treatment, because if you stop this treatment, you are going to have a rebound effect of deterioration of the status of the patient in the form of heart failure or myocardial infarction or all other subsequent. So the American College of Cardiology confirmed that you have to continue, and then the European Society of Cardiology all, and Saudi Heart Association, all of them recommend by now to continue angiotensin converting ARB treatment of patients who need that one. And the current treatment that we have to restrict the washing hand, the hygiene, avoiding close contact, use a medication, and then reduce the salt, reduce the weight, keep exercise, continue mental relaxation, and uses of different type of fruits and vegetables. So treatment is not available up till now, as you have heard that there is trials to treat, but the treatment is not really well established. That different type of treatment is now trying to be implemented, including antiviral, hydroxychloroquine, azithromycin, etc. But up till now, it is not strongly evident. However, that we need to know that we have to keep patients' hygiene, diet, and medication. And you have to communicate with your patient for controlling of his blood pressure, because important to control blood pressure, you are going to avoid the reduction, or you are going to avoid the outcomes. So this is my conclusion. The last slide, in fact, that hypertension is a common disease and then undertreated. As you can see, 10% of patients in China, and then 10% control in China, but 70% uncontrolled worldwide. And the COVID-19 infection is higher in patients with hypertension and cardiovascular disease. Then advise patients for the hypertension and COVID to have good hygiene, good diet, good blood pressure control, and do not change the hypertensive medication, including angiotensin converting enzyme inhibitor and angiotensin receptor blocker, because if you decide to stop this medication, you are going to have a deterioration of your patient, and probably it is not advisable at all up till now. Dr. Walid touched on the AC2 as a protective for the cardiovascular and lung injury. Similarly, some of the reports came that it may be harmful. However, the reports for ACE2 that it is more protective is more than that it is harmful. Number one. Number two, that angiotensin receptor blocker, angiotensin converting enzyme inhibitor has nothing to do with the deterioration of patient with COVID-19 infection. So by this, we will stop and we will start looking for your questions, and then the questions of your questions, and then we will answer the questions and from your people. So we have multiple questions here that
I screened some of them, Dr. Mustafa, while you were giving your lecture. Yeah. I can answer the ones that are probably pertaining to me.
Yes, please.
Now, one is asking about most of the deaths due to the virus in patients with chronic disease. Again, this is a misconcept that those with respiratory disease have the highest mortality. No, according to the most of the reports, those with cardiovascular disease, with underlying cardiovascular disease, actually had the highest mortality when infected with COVID-19, followed by diabetes, interestingly, then chronic lung disease, and then hypertension. So still, cardiovascular disease has the highest complication and outcome. There has been lots of questions about ACE inhibitors and ARBs use, and I think Dr. Mustafa answered it very clearly. All the bodies, the scientific bodies worldwide, do not recommend stopping ACE or ARBs for patients, even if they are infected with COVID-19, because the evidence that it increases the risk is very, very scarce in that part, and you risk the patient worsening after that. There's a question about the routine use of D-dimer and low molecular weight heparin in patients with COVID-19. Now, I can tell you from the discussion with people who have been managing worldwide COVID-19 that they do recommend prophylactic low molecular weight heparin unless they present with evidence of hypercoagulation or coagulopathy, and the routine use of checking of D-dimer was not recommended by everyone unless there was other evidence for that. There is a question about extent of are ventilators helpful in ICU patients? ECMO the next option? Of course, you manage every patient according to his presentation. If they are sick, if they require ICU, if they require ventilation, they require support, hemodynamic support, whether you start with regular inotropes and ventilation or require ECMO. There have been several reports of patients recovering after utilizing ECMO in these patients.
Okay, there is some, do you hear me, Dr. Walid?
Yes, yes, we can hear you.
Okay, there is a question here about should we stop ACE or ARB in patient who's ventilated or who's in the intensive care and he is having hypotension on vasopressor. Of course, once the patient developed hypotension, any antihypertensive medication should be on hold until the patient improved by the vasopressor and he come out. That's the answer for this question. Yes, you can stop all, whatever the antihypertensive medication. There is another question is that they are saying that if any patient with heart failure, should we screen for the COVID-19? I think if the patients require admission, probably yes. But if the patient is not requiring admission, you don't need every patient with heart failure to screen. Do you think so, Dr. Walid?
Screen for?
Screening for COVID-19 in every patient with heart failure.
No, I think you, of course, mass screening now is up in the air and people are talking about it for everyone. But I think if you should only screen if you have a picture of COVID, a classic COVID. But new onset heart failure, because even if you have positive COVID, and he didn't come with the picture of COVID, it might be just another cause. It's not classic that we screen for viruses for every patient who has new onset heart failure.
Yeah. I have a question here. They said any data about course of COVID-19 among hypertensive patients? The question here is that they found that there is a correlation, that there is the hypertensive, 72% of hypertensive of COVID patients, they are probably hypertensive with variable degree of antihypertensive medication. But once they look into the multivariate analysis, they found that there is no direct correlation. In another word, the hypertension itself does not make the person susceptible to hypertension, to COVID-19 by itself. But because the hypertension is common and because of the old age is common, the combination of old age with hypertension, they are more susceptible to have the complication. So up till now, the multivariate analysis unable to blame the hypertensive as a cause of deterioration. But because of the age and the other confounding factors for hypertensive patient, as you know, with multiple risk factors, very rarely you will have a patient with hypertension alone without other comorbidities. That's why the patient with hypertension and the other comorbidities, they are really developing further worse course among the other. The other thing is, the other question is, any specific management for COVID myocarditis, Dr. Walid?
Nothing yet. Unfortunately, if there is COVID myocarditis, it's just supportive therapy until we get something specific for COVID-19.
Yeah, another question here. They said, why hypertension and diabetic had a high risk before the COVID? In fact, they are, as we have said, that they are older people generally. Secondly, they are immunosuppressed. By definition, diabetic patient is an immunosuppressed patient, and then subsequently he is susceptible for any type of infection. That's why they have a higher risk for development of any infections, regardless of the COVID-19. But because of COVID-19 is fast spreading, it is spread very fast all over, with faster, it makes the massive involvement of patient with comorbid condition and hypertension. How is the hypertension do bad consequences, or it is just a research finding? No, it is bad consequences because I have said to you that because of the comorbid condition associated with the infection or with the susceptible in infection, and the research has been confirming that this is the case because of the multiple comorbidity.
I think because hypertensive patients are also vasculopaths, so their vasculature is diseased, and part of the involvement of COVID-19 is microangiopathy. So if you already have a diseased vessel, you're more susceptible to complications, whether it's more angiopathic disease or infarctions or hypercoagulability.
Okay, another question here. They said, I read that we should start ACE inhibitor and or ARBs in patients with COVID-19 patient, even if they are not taking it before. I think any hypertensive patient should be treated the same way according to the guideline. ACE inhibitor or ARBs, regardless of the infection is present or not present. Because up till now, we know the value of this. Although there is some people thinks that we should not initiate the ACE inhibitor or ARBs, but this is a minority without any evidence. I think you can start treating your patient as usual, whatever the indication for you. We know that the indication number one for any hypertensive patient, ACE or ARB associated with amlodipine as a calcium channel blocker. Okay, then another question, that non-steroidal anti-inflammatory like ibuprofen related with COVID-19. Dr. Walid, you want to answer this question or you want me to try to answer it?
Go ahead, because there were many reports that ACE and NSAIDs, specifically ibuprofen, increased the risk. I think it's because of the prostaglandins. I can't recall the actual mechanism if you do.
Yeah, again, I think what happened that, as we have said, that COVID-19 is a multi-system disorder. So this is number one. Number two, it is affecting the platelets. It is affecting the hypercoagulable state. It is affecting the brain, kidneys, all. So there is a lot of interaction in the body with a lot of anti-inflammatory release. The uses of non-steroidal anti-inflammatory has no obvious rule at this stage. However, if the ibuprofen and the drug is being used, they might even precipitate bleeding. And the risk of bleeding may be there as well. So I think I will not recommend that non-steroidal anti-inflammatory should be used, but very clearly that paracetamol can be used for the or for the improvement of fever. So fever can be treated by paracetamol rather than non-steroidal anti-inflammatory drug. Has antiviral such as oseltamivir or not been effective at all on COVID-19? I think now the antiviral, there is a lot of trial and there is a lot of experiment. There is some people think that there is improvement of the course of the disease of COVID-19, but nothing changed the mortality with using of the antiviral. However, the trial is still ongoing and has been announced in the US that there is a trial with the antiviral medication to be used with the HIV. But the outcome of those studies has not been yet provided for us to recommend uses of antiviral medication. Then is the COVID medication for the cardiac patient can cause VT, Dr. Walid?
Not all, of course. Well, as I said, patients with COVID-19, because of the inflammatory involvement and myocardial involvement, they're at increased risk of VT by itself or arrhythmias in general. But we know that some of them, specifically the combination of hydroxychloroquine and azathioprine, can prolong QT and lead to ventricular arrhythmias.
Okay, now again, a lot of questions coming about the mechanism of hypertension and COVID-19. As we have said, it's a comorbid condition affecting elderly, immunosuppressed patient, multi-organ involvement, and they will be more affected to be there. However, the direct relationship is not clear, although ACE2, angiotensin converting enzyme 2, has been blamed, but that for the experimental animal with controversial results. Up to now, I believe myself that angiotensin converting enzyme 2 is probably protective for the lung, for preventing for the lung injury. And there is a recombinant. They are trying to do a recombinant angiotensin converting enzyme 2 to be as a treatment, in fact. And then the trial is still ongoing. It's not been yet released. What about patients?
didn't find the difference in infection and outcomes between patients who were already on ACE inhibitors, ARBs, or not. So blaming the ACE or ARBs in the pathology, I think, is not justified. Those patients had the same outcomes whether they were or not on ACE inhibitors.
Very important question came from one of our colleagues, said, what mitral valve prolapse, are they at a higher risk for COVID-19? Well, if the mitral valve prolapse is confirmed with the presence of mitral regurgitation, then you can consider this patient as a cardiovascular disease patient, particularly if he is having other comorbid condition or as he's older age. Then probably, yes, he might be on more likely to be involved with any infection, similar to any cardiovascular disease. Cardiovascular disease, diabetes, and higher mortality. What about renal patient? Do you want to comment about the renal?
I did show in the studies reported from China that those with existing chronic diseases in general, including chronic kidney disease, had a higher risk of worse outcomes, higher risk of infection, and worse outcomes. So they are at higher risk as well.
So how about the shock patient with myocarditis? Is the drug, vasopressor drug, should be used routinely similar to the patient with myocarditis without COVID, Dr. Walid?
So the management is the same, whether you have COVID or not. You manage the hemodynamic findings. If the patient is in a cardiogenic shock, whatever the cause is, myocarditis or whatever, you will support him hemodynamically with inotropes, vasopressors, probably cardiac support, hemodynamic assist devices, ECMO, whatever it is. There's no difference between COVID and non-COVID.
Okay, Sayyid Gibran asking about the role of ECMO in the presence of ICU patient with hypotension.
In general, it's one of the supporting methods. The problem with ECMO, in the absence of lung involvement, there are reports of increasing pulmonary edema. So we don't recommend it just for myocardial support. There are short-term vascular supports like probably Impella or tandem heart that are preferable, or if you can use or if you can use central ECMO, but peripheral ECMO alone routinely is not recommended in the absence of lung involvement.
Okay, Dr. Taha Isa here, he is asking about do you need to change ACE or ARB in patient with hypertension? As we have explained in the lecture that we don't need to change at all. We have to continue the same treatment patient on as far as his blood pressure control. And the most important is to control the blood pressure. And if he is on ARB, don't change, don't stop. Could we initiate ARB AC in COVID patient who don't have hypertension? Again, similar question. We said you cannot initiate it up till now. It is not evidence-based medicine, but we will not recommend it up till now if the patient is not hypertensive, as the rule of angiotensin converting enzyme, our ARB, is not very strongly recommended as a treatment for COVID-19. They said how and why combination ARBs and calcium channel blocker increase the compliance. Yes, because they are in one pill. The one pill combined pill is relatively clear, and the study has shown that it is improving the compliance and adherence. Instead of taking one tablet, you are taking 2 or 3. Of course, the compliance will improve. What will you advise all health workers who have diabetes, hypertension, and cardiac problem with dealing with a patient with COVID-19, Dr. Walid?
Having heart problems?
No, yeah, patient with heart problem, diabetic, hypertension, and he's a health provider.
Yes.
What to do for that patient? What you recommend to?
I recommend for everyone, or has been recommended for everyone, take all the precautions that you could. PPEs all the time, distancing as much as possible, just protection as much as possible, because you are at high risk, but nothing more than the protective measures.
Dr. Walid, I think, I agree with you. That's absolutely correct. But one question here, he said, Should we use the ventilator which has been used in a patient with COVID-19 in another patient?
Yeah, it's like any other infection. If it goes through infection control measures and gets very well reprocessed and cleaned, why not? I think so.
Another question here from one of our colleagues. He said, what is the best markers for poor cardiovascular complication for early detection and management? Markers, any markers you think it should be considered as a marker of a poor prognosis?
Yes, there have been several studies actually in patients with diabetes and hypertension, patients with chronic disease, using pro-BNP natriuretic peptides early on predicted outcomes 6 months earlier before the involvement of the heart, whether it was heart failure or LVH. And there was a recent study actually showing that troponins were good markers for prognosis in patients who haven't even developed heart disease yet, but specifically natriuretic peptides pro-BNP in patients with chronic disease predicts cardiovascular disease.
Very interesting question from Dr. Malik Munah Al-Anzi. He said, how frequently heart failure patients should visit the clinic these days? I think you have been touching on that issue, but
yes.
You will just emphasize
now,
maybe.
If he's talking about these days, I do recommend telemedicine as much as possible. Communicate with your doctors through the systems or through the phone. This is the best way to get it. In general, the follow-ups depend on the patient's situation. If the patient is sick or just recently discharged, we usually recommend seeing the patients within 3 to 7 days. I know the health systems cannot really afford that, but this is the recommendation. If patient is less sick, within 4 weeks, and if they're really stable, 3 to 6 months regular follow-ups are okay.
There is one question. In fact, there are two questions together. From one from the Dr. Rashid Iqbal Khan. He said, 9 years ago, I have a patient who had the coronary artery bypass graft. And then how about hypercholesterolemia patient at risk of COVID? Yes, all risk factors, including hypercholesterolemia, they are at risk of COVID-19 infection because the hypercholesterolemia will not be alone. And it is hypercholesterolemia is the reason for the development of vasculopathy. And subsequently, treatment with the statin or with the PCSK9 inhibitor is very important to continue because they have proven that they have no relationship with deterioration of immunity of patients with COVID-19. For CABG patient, he's a cardiovascular patient. He is more likely to develop, or he more likely to have the infection. Here again, another question: is there a difference between the management of Middle East respiratory syndrome and the COVID-19, Dr. Walid?
Between, sorry?
MERS-CoV and COVID-19.
I don't think there is. We were still learning, but we haven't. Now there are talks about fatality higher in patients with MERS-CoV, but the spread is higher in patients in COVID-19. So maybe according to the reports that those who had MERS-CoV had a higher mortality and higher fatality rate than COVID-19. As you can see, we're screening a lot of patients becoming positive, but alhamdulillah, it's less fatal than MERS-CoV.
Okay, Mukhtar here, Dr. Mukhtar asking about combination of paracetamol and non-steroidal anti-inflammatory drugs. I think the role of a non-steroidal anti-inflammatory drug is not there, but paracetamol is well-established treatment for high temperature. How can antimicrobial drug with hydroxychloroquine be effective for treating viral infection by COVID-19? He's asking what is the mechanism.
I don't know.
But I think the mechanism, they are telling that the hydroxychloroquine is trying to protect the cell, protecting the cell of the epithelial cell of the lung from having contact with the viral replication.
I think we completed 1 hour, Dr. Mustafa.
Yeah, you want us
to... There are lots of questions, mashallah.
Yeah, there is a lot of questions, but I'm very interested to continue, right? But the time limit from the host we will not be able to exceed. However, we will take the last question here, and then we will thanks all those people who get this question to us. He said, at treated COVID-19 patient who are discharged, is he at risk to the community? You will take this question.
Yeah. As you've seen in the graph I've showed, after you clear your virus, you should be at no risk to the community, because the virus have been shed, and that's why you see people are being quarantined for 2 weeks if they show evidence until they clear the virus out, and then they can go back to the community with no specific precautions.
Okay, I think we have we divided the time to three slots. Slots number, the first slots for Dr. Walid Al-Habib talk, the second slot for the hypertension talk, and the third slots for answering the question. Although we cannot catch up all the question, we have multiple questions, all of them interesting and worth to answer. I think we will call any one of the company to sponsor another meeting for answering all of these questions. The last thing is which I think we should comment about it is the uses of steroid in patients with COVID. The steroid use of COVID is similar to the steroid use in any type of viral illnesses. It is the last resort. You might use it with caution and with antiviral medication. So first of all, thank you very much for all of you who attended, and thank you very much for the sponsor, for the company. Thank you very much for the Saudi Heart Association for their accepting to conduct this interview, as well as Dr. Walid Al-Habib. I'm so thankful for his highlight, very important information today. And then we will summarize that the most important thing is to try to avoid the contact with infection, particularly those at a high risk with multiple risk factors. Once you have developed the disease, you should be on the treatment arena, and the most available drug now is still only hydroxychloroquine and maybe some other viral with paracetamol and respiratory care. Thank you very much for all of you, and then we'll appreciate. I hope that we will have another session sometime later. Thank you very much.
Thank you, Dr. Mustafa and the SHA and the sponsor. Have a good night.